Hello everyone, my name is Seung-Hyuk Kim, Professor of Radiology, Seoul National University Hospital. In this session, I'd like to talk on imaging findings of endometriosis and adenomyosis. Endometriosis and adenomyosis are closely related conditions, but the difference is location. In endometriosis, functionalist layer of endometrium is located outside of the uterus, while in adenomyosis, basalis endometrium is located in the myometrium. This is a schema of uterine wall showing uterine cavity, functional and basal layers of endometrium and myometrium. This white layer indicates inner myometrium representing junctional zone, which appears as a low signal intensity layer at T2 weighted MRI. This junctional zone is important in adenomyosis. We may use hysterosalpingography, ultrasound, CT, or MRI in making diagnosis of endometriosis and adenomyosis, but mainstay of imaging is ultrasound and MRI. Main MRI sequences used in diagnosis of endometriosis and adenomyosis are T1 weighted imaging, T2 weighted imaging, and fast suppressed T1 weighted imaging. We also use contrast enhanced imaging with subtraction and diffusion weighted imaging with ADC map. Let's begin with endometriosis. Endometriosis is very common and affects about 10% of women of reproductive age. It causes recurrent cyclic bleeding and inflammatory and fibrotic changes. The lesion varies from small implants to large endometriotic cysts or endometriomas. Ultrasound is excellent in evaluation of endometriomas, but is not good in detection of endometriotic implants and adhesions. Endometrioma appears as a thick-walled cystic mass with diffuse low-level internal echo and often has multilocular appearance with septations. Endometriomas usually have homogeneous hypoechoic contents. Sometimes endometriomas have heterogeneous internal echoes, and rarely it can be totally anechoic. If we see echogenic foci attached to the inner wall of a cystic mass having fine internal echoes, it is a highly suggestive finding of an endometrioma. These echogenic foci represent contracted old clots attached to the inner wall of an endometrioma. Mature cystic teratoma and hemorrhagic ovarian cyst may look similar to endometriosis at ultrasound. These are 4 different cases of mature cystic teratoma, and these are 2 different cases of hemorrhagic ovarian cyst. Cystic neoplasm may also look similar to endometriosis at ultrasound. This is a case of endometriosis, this is a case of serous cystadenoma, and this is a case of mucinous cystadenoma. Differentiation between endometriosis and the hemorrhagic ovarian cyst is especially important because treatment is different. Usually, hemorrhagic ovarian cyst does not need treatment. Because of fibrin strands, hemorrhagic ovarian cyst characteristically has reticular, fishnet, or lace-like internal echoes, as you see in these 2 different cases. Hemorrhagic ovarian cysts usually regress spontaneously 30% within 2 weeks and 100% within 8 weeks. One interesting finding useful in this differentiation is so-called acoustic streaming, which means movement of internal echoes within a cystic lesion. We often see acoustic streaming in hemorrhagic ovarian cyst, but not in endometriosis. MRI is helpful in determining the extent of endometriosis, especially when the lesion is deep infiltrating and laparoscopic inspection is limited by adhesions like this case. MRI is highly accurate in diagnosis of endometriosis because it typically shows high signal intensity on T1 weighted image, not suppressed on fast suppressed image. Decrease of signal intensity at T2 weighted image, which is called shading, is caused by concentrated blood product of the chronic cyclic hemorrhage and high viscosity of the contents. The finding of T2 shading range from faint shading to complete signal void or dependent layering, like these 4 different cases. This is a case of endometriosis composed of multiple locules of endometrioma. On fast suppressed T1 weighted image, all locules show homogeneous high signal intensity, but on T2 weighted image, these locules show various signal intensities due to different degree of shading. We may see cases of endometriosis without T2 shading, like this case. T2, T1, fast suppressed T1 weighted images. We do not see a finding of shading in T2 weighted image. Cyst wall of endometrioma usually shows low signal intensity on both T1 and T2 weighted images because of fibrous components and hemosiderin-laden macrophages. Sometimes we may see wall calcifications. Infrequently, endometriosis looks mainly solid. Here is a mass that has internal high signal intensity areas at T1 weighted image and T2 shading. This mass has an appearance similar to the uterus, so it is called a miniature uterus or uterus-like mass. This CT shows wall calcifications, and this is a gross specimen. If we have a difficulty in differentiation between endometriosis and hemorrhagic ovarian cyst at ultrasound, we may use MRI. T2 shading is not very specific for endometriosis. If we see dark spots at T2 weighted image like these 3 different cases of endometriosis, this finding has high specificity of chronic hemorrhage and therefore is useful to differentiate endometriosis from hemorrhagic ovarian cysts. There was a nice article published in 2014 in Radiology reporting the utility of T2 dark spot sign. In this article, they compared T2 shading and T2 dark spot sign in 45 endometriomas and 25 hemorrhagic ovarian cysts and found that T2 shading sign has high sensitivity but low specificity. In contrast, T2 dark spot sign has low sensitivity but high specificity. It means that these 2 signs are complementary to each other, and if we see both signs, we may make a diagnosis of endometrioma with high sensitivity and high specificity, so high accuracy. Adhesion is the most common and important sequelae of endometriosis. Findings suggesting adhesion are variable, including posterior displacement of the uterus and ovaries, elevation of the posterior vaginal fornix, angulation of bowel loops, speculated low-intensity strains on the interface of pelvic organs, hydrosalpinx, and loculated fluid collections, so-called peritoneal inclusion cyst. Here you see endometriomas on both sides and the severe adhesions between those endometriomas and the uterus. Another case of multiple endometriomas and the severe adhesion among them. Because of perilesional adhesion, often endometriosis is associated with peritoneal inclusion cyst, which is localized fluid collection due to peritoneal adhesion and adjacent functional ovarian tissues. Here you see an endometrioma that has high signal intensity at fast suppressed T1 weighted image and T2 shading. This cystic lesion adjacent to this endometrioma is peritoneal inclusion cyst. You can see endometrioma and peritoneal inclusion cyst at ultrasound. Deep pelvic endometriosis, also known as deep infiltrating endometriosis, is a specific form of endometriosis that has subperitoneal invasion more than 5 mm in depth. Common involving sites are fibromuscular pelvic structures such as rectovaginal septum, uterosacral ligaments, vagina, alimentary tract, and the urinary tract. This is a case of deep infiltrating endometriosis involving urinary bladder. You see irregular low signal intensity infiltrations across the uterus and bladder. And this is a laparoscopic image showing those infiltrations and adhesions. Another case of deep pelvic endometriosis involving urinary bladder, and we see soft tissue lesion here between uterus and bladder. High signal intensity foci here on T1 and fast suppressed T1 weighted images are surrounded by low intensity fibrous tissues. This cystoscopic image shows hemorrhagic lesion bulging into the bladder lumen, and this lesion is probably that high intensity lesion at T1 weighted MR images. This is a case of endometriosis involving rectum. We see irregular soft tissue lesion at CT and MRI that has mainly low signal intensity due to fibrosis, but has high signal intensity foci at T1 weighted image. This is an endoscopic image of the rectum. This is a case of endometriosis showing characteristic appearance. You see bilateral endometriomas at MRI and ultrasound. You see low intensity foci at T2 weighted MRI that is probably same as this echogenic foci at ultrasound and is probably old retracting clot. On this image, probably you can imagine a face of an animal with big ears, so this appearance is called Mickey Mouse sign. At ultrasound, you may see endometriomas involving both ovaries are closely adherent to each other, and this appearance is called kissing ovary sign. These three different cases of endometriosis all show similar appearance of Mickey Mouse and sometimes may mimic face of a cat. Another similar case, but this time to my eye, this fast suppressed T1 weighted image looks like tiger's eyes in the dark. Endometriosis may be associated with tumors, most commonly endometrioid carcinoma, followed by clear cell carcinoma. This is such a case. Ultrasound shows a cystic mass with internal solid portion in the left ovary. Here is a linear flow signal at Doppler ultrasound, indicating that this is a solid tumor lesion rather than a blood clot. Contrast-enhanced MRI shows enhancement of the solid portion, and this mass was confirmed as mixed Müllerian borderline tumor developed at inner wall of an endometrioma. Another similar patient, MRI shows a large cystic mass with a mural nodule. The mass shows high signal intensity at T1 weighted images, subtle homogeneous shading at T2 weighted image, enhancement of the mural nodule at subtraction image of contrast-enhanced fast suppressed T1 MRI. The mural nodule clearly shows a strong diffusion restriction at diffusion weighted image and ADC map. This mass was poorly differentiated carcinoma associated with endometriosis. Here is a large cystic mass with fine internal echo and multiple solid-looking echogenic lesions at ultrasound and T2 weighted MRI. We do not see any enhancement of those nodular lesions at subtraction enhancement MRI. So these solid-looking lesions are blood clots in the dependent portion of an endometrioma. Now let's move on to adenomyosis, which is heterotopic endometrial tissue within myometrium. Characteristic findings of adenomyosis at hysterosalpingography is opacification of these irregular tracts in the myometrium, resulting in flame-like appearance. Ultrasound and T2 weighted MRI of the same patient showing diffuse enlargement of the uterus due to thickened myometrium. high-intensity foci of ectopic endometrial tissue and the surrounding extensive low-intensity at T2-weighted MRI due to smooth muscle hyperplasia and fibrosis. Most common findings of adenomyosis at ultrasound is poorly demarcated hypoechoic areas in the myometrium due to smooth muscle hyperplasia. We may see multiple small cystic lesions resulting from dilated endometrial glands or hemorrhagic foci within heterotopic endometrial tissues. Sometimes we may see echogenic finger-like projections or linear striations from endometrium towards the myometrial direction. This phenomenon may result in appearance mimicking widening of echogenic endometrium and is called pseudo-widening of endometrium. MRI is highly accurate in diagnosis of adenomyosis, and the most important anatomic landmark is junctional zone that appears as a low signal intensity layer at T2-weighted MRI. Anatomically, this junctional zone is the inner layer of myometrium. Normally, thickness of junctional zone is less than 8 mm, and if it is thicker than 12 mm, we may suspect adenomyosis. This is a case of adenomyosis showing thickening of junctional zone, mainly on the right side. This low signal intensity is due to myometrial hyperplasia around heterotopic endometrial tissue. These are three different cases of adenomyosis. These hyperintense foci on T2-weighted images represent heterotopic endometrial tissue and cystic dilatation of the glands, while these hyperintense foci on T1-weighted images are hemorrhagic areas. So if we compare T2 and T1-weighted images together, we may assess the extent of heterotopic endometrial tissue, extent of hemorrhage, and extent of surrounding smooth muscle hyperplasia. Here is another case of diffuse adenomyosis in the posterior myometrium. We see heterotopic endometrial tissues and the smooth muscle hyperplasia at T2-weighted image and the extent of hemorrhage at T1-weighted image. These findings are well correlated with gross specimen findings. Basically, adenomyosis is a diffuse disease, but it has focal forms. If the lesion is focal and has mass-like appearance, it is called adenomyoma. If it is polyp-like, it is called polypoid adenomyoma or adenomyomatous polyp, and if it has a cystic appearance, it is called cystic adenomyosis or adenomyotic cyst. This is a case of focal mass-forming adenomyosis or adenomyoma in the uterine fundus. This is a case of cystic adenomyosis or adenomyotic cyst involving uterine cervix. Sometimes we see interesting findings of adenomyosis, mostly in patients with endometriosis. By definition, lesions of adenomyosis begins from the inner myometrium or junctional zone by infiltration of endometrial tissue towards the myometrial side. But in this case, findings of adenomyosis are seen in the subserosal myometrium adjacent to endometriosis lesions with normal junctional zone. Probably these lesions of adenomyosis is a result of infiltration from lesions of endometriosis, and so these lesions may be called invasive solid endometriosis of myometrium, subserosal adenomyosis-like lesions, or outside-in adenomyosis. Personally, I prefer using the last term, outside-in adenomyosis. You may clearly see continuity of hemorrhagic lesions of endometrioma and adenomyosis on this fast-suppressed T1-weighted image. Another case of outside-in adenomyosis resulting from endometriosis lesions infiltrating into myometrium. Here is another similar case of endometrioma and adjacent outside-in adenomyosis lesion in the posterior myometrium. Significance of this situation is that It will be impossible to remove this endometrioma clearly because of severe adhesion between endometrioma and the uterus. This is a specimen photo of this endometrioma, removed fragment by fragment. In summary, I would say endometriosis and adenomyosis are closely related conditions but different manifestations. Transvaginal ultrasound is the first-line imaging, and the MRI is the best imaging modality for diagnosis. And familiarity to these imaging findings will be necessary for proper diagnosis and management.